Hi, welcome to my channel Learn Pain Management. Today's topic is managing discogenic pain. We saw the videos you must have seen, the differential diagnosis of back with leg pain, differential diagnosis of neck with arm pain. In that, we had mentioned the discogenic pain, the pain arising from intervertebral disc. Okay, that is called discogenic pain. Now, how to manage once you've diagnosed that the pain is discogenic? Then, what are the different treatment options that we are going to explore in this lecture? First of all, what I feel is you must pay attention to the anatomy and the innervation of the disc. What you see in the picture is the disc. The green surrounding is called annulus fibrosus. It's a tough fibrous structure which basically gives a security to the inner soft nucleus pulposus so that it doesn't come out. And nucleus pulposus is basically the shock absorber, and the annulus fibrosus is what gives protection to the nucleus pulposus. Interesting thing is the nucleus pulposus does not have innervation, but the annulus fibrosus has got innervation. The innervation is from the segmental nerve and the small nerves entering the disc. Okay, and then there is a sympathetic supply. This is sympathetic trunk anterolateral to the disc. From there, the communications go to the dorsal root ganglion, which is in the foramen. So in the intervertebral foramen, there is a dorsal root ganglion. This is the seat of interest. Here, the sympathetic and somatic supply of the disc both converge. All right. So if you treat the dorsal root ganglion, you can take away the pain of the disc. It has to be bilateral. Okay. So if you treat the dorsal root ganglion bilateral by blocking these two, then you will block the nerve supply. Now, why the pain comes from the disc? Whenever the annulus fibrosus gets a cut, then the nerves are irritated in the periphery, that is the annulus fibrosus. Plus the nucleus from the center, it peeps in and goes into the annulus fibrosus. So this nucleus is very irritating and that causes the nerve irritation. So one gets pain actually that is along the back and maybe going down the leg. Okay, so this is discogenic pain and the important clinical pearls of the anatomy. The dorsal root ganglion is a seat where the somatic supply and the sympathetic supply of the disc converges. So if you can block dorsal root ganglion, you can block the pain coming from the intervertebral disc. Now coming to the common reasons. The first and foremost is most common, that is degeneration. With degeneration, there becomes you find the cut in the annulus, that is called annular tears, and then the nucleus moves out, and because of this there is an inflammation and increased pressure in the disc called internal disc disruption and raised intradiscal pressure. This is the most common cause of the chronic discogenic pain. There can be disc metastasis. Yes, that can also cause pain. At times, there is inflammatory, infective reason called discitis, either iatrogenic or through bloodstream. And sometimes in the trauma, the disc may get traumatized and one gets pain. But the most common we come across in a non-malignant, non-infective, and non-traumatic patient is the degenerative spine giving internal disc disruption and causing increased internal disc pressure. That is the main reason of discogenic pain. Now, when it comes to treating the pain, there are two approaches. One is mechanical and another is chemical. What is mechanical? You try and remove the disc that is the source of pain. Okay, and another is chemical. Now, because there is an internal disc disruption, because there is a raised intradiscal pressure, the nerves are irritated and then nerves get hypersensitized. So, the Disc disruption is the cause and hypersensitization is the effect leading to pain. Now, mechanical options, they treat the cause, and chemical reason, they try to control the effect. All right. Here, the theory is different. They believe the people who work using the chemical methods, they believe that nature takes its own course and the disc gradually degenerates, and you have to just buy the time and relieve the pain and improve the quality of life, and things settle down automatically. Whereas there is a subgroup of people who believe that no, we should remove the disc, which is the offending agent, and give the patient relief. So these are two different approaches, mechanical approach and chemical approach. All right. Now what are the options? In mechanical approach, basically you are trying to remove the part of the disc. It can be done by disc decompressor, disc annuloplasty, disc biocuplasty, percutaneous nucleoplasty. Then there is something called disc FX. Then there is a laser discectomy. Then there is an endoscopic discectomy. Then there is an intradiscal ozone injection or intradiscal steroid injection. All this basically debulk the disc. And in chemical options, interlaminar epidural, it tries to desensitize the nerve. Transforaminal epidural, caudal epidural, distal sodium channel blocks, the new concept coined by three orthopedic surgeons, Dr. Gore, Dr. Divakar, and Dr. L. Prakash. This is distal sodium channel block. Then there's a peripheral nerve block, which is the offshoot of distal sodium channel block. And there is hypodermic dermatomal needling. So these are the reasons with which we try and control the hypersensitization. There are new options which are coming up to prevent the degeneration go further. This is to be used in very, very, very early degeneration. And once there is a intradiscal raised pressure and lot of internal disruption, uh, I personally doubt how much these options help. But people are using, and some are claiming that intradiscal platelet-rich plasma and intradiscal stem cell therapy can be of help in very, very early disc degeneration. Now coming to the mechanical methods. What are the benefits and what are the negatives? The pros are it removes the offending material and it proposes to prevent recurrence. It says that there is likely immediate effect, right? The cons are many times we have seen that in MRI there are a lot of changes, but pain pattern differ. Patient may have a lot of things in MRI, but patient may not have pain. Or MRI may be nearly normal, or just notional changes will be there in MRI, but there will be a lot of pain. So this puts little difficulty in following the mechanical methods. Second is when offender removal, because of this, the offender removal may not be adequate always, right? And recurrence can be there. Another thing is you remove the disc, but if the nerve remains hypersensitized, then the pain prevails. So this is the limitation. Disc decompressor. Coming to the various options. Previously, we have done this. Now, very few people do it, or at least I have not heard people doing it of late. But yes, it is still available in market. Decompressor is this kind of instrument. This is a handle, there's a switch. This is a chamber where once this rotates, this is the enlarged tip which is seen here. It rotates. Once you press the button, this rotates. And this goes actually inside the disc in the nucleus pulposus. This rotates, churns the nucleus and pulls it back. And it is collected here. So you are removing small central nucleus by disc decompressor. Okay. The problems faced with this disc compressor were if you hit the annulus fibrosus and you disturb it, then post decompression there used to be a lot of pain, and which used to mimic like discitis. So this was one of the problem which people had faced. But yes, this is one option. Second is disc annuloplasty. Herein, uh, uh, needle goes in the center. Then there's a van which goes and rests itself between the nucleus and the annulus, supposedly at the inner end of the annulus annular tear. All right, and then a radio frequency wave is passed. This proposes to seal the annular tear. All right, this can be from in out or this can be directly in the annulus because of two needles just put and current pass through it. Idea is to seal the annulus tear and prevent the nucleus to migrate back. Okay, so this is the annulus tear. Can you see this annular tear? This is annulus, this is nucleus, and this is tear. If the nucleus goes out, then there is a irritation of the nerve and there is a pain, which the annuloplasty does by radiofrequency ablation of the innermost layer of the annular tear to seal and prevent the pain. Disc biaxioplasty, part of the same thing. What you do is basically put two needles in the annulus fibrosus and pass current in it, and this tends to seal the uh, what do you say, inner end of the uh, annulus fibrosus. All right. Percutaneous nucleoplasty. This was one instrument wherein actually a small needle was passed in the center of the nucleus, and the radiofrequency catheter was passed, and it used to move in all three directions to make channels in the nucleus, and that used to get burned and evaporated, and the vapor used to come out. So basically this was again done to debulk the disc. Disc FX. It is a miniature form of endoscopic discectomy in which the scope goes inside the center of the disc where there is a tear, posterior part, and then it tries to remove the small portion of the disc, and by RF it tries to seal the annulus from inside. This is called disc FX. Okay, this is partly visualized, partly not. Okay. Percutaneous laser disc recompression. This also came and went. Herein again, the probe was put right into the center, especially where there used to be the prolapse, protrusion, and the laser used to burn and suck the uh, annulus, and then it used to seal the the nucleus, and then it used to seal the annular tear. Okay, so laser was also there, but somehow people were not happy with the results, and it just fizzled out. In my career, I have seen that all these different instruments came and went. Every year, there used to be some new instrument telling that the previous was having limitations, so we have introduced new. And every time a new kid on the block used to come. Then came the endoscopic discectomy. This is purely surgical option. Nowadays, even done by pain specialists. Uh, I don't know whether what is the legal stand, but yes, endoscopic discectomy is going on. Probably they might be having their own correct reasonings to do it. And endoscopic discectomy, what it does is basically try and remove the part of the nucleus which is offending agent and clear the nerve root so that the pressure on the nerve root goes away and the internal disc uh, pressure reduces. So this is endoscopic discectomy. It does give good results, of course, but again, if the nerve sensitization remains, then the pain may persist. And whatever you do, this is miniature endoscopic surgery. It has its own risks, own limitations, and a big learning curve. So I would suggest, unless you are very much properly trained, do not just start it for the sake of doing it. Learn it from a correct person, practice with that person for a spell of time under the uh, observation, then probably you may take up, provided your legal system allows it to do it. Intradiscal ozone and steroid. This is still practiced by many people, in which a needle is passed inside the nucleus pulposus and ozone is injected or intradiscal steroid injection is given. The idea is that you try and dehydrate the disc. So this actually does debulking, but of a different sort. Okay. Now chemical methods. What do you mean by chemical methods? By chemical method, I mean putting chemicals around the nerves to desensitize the hypersensitized nerves and reset the pain system or the nervous system so that the patient doesn't feel pain. the cause may remain and the nature takes its own course to heal it. Okay, so there are few people who follow this. I am one of them. The pros is it desensitizes nerves, it is minimally invasive, uh, the cause may persist, but the effect is controlled. The cause takes natural course of healing. The cons here are the recurrence can be there. The duration effect varies with the patient. Again, the same thing is true even for the mechanical options as well. Interlaminar epidural steroid. The basic idea is to put the epidural steroid injection. Okay, it can be interlaminar, it can be transphenomenal, or it can be caudal. Okay, so what do you do in interlaminar? This, as an anesthetist, we have been doing it over years, right? So basically, either midline or paramedian approach, you try and put the medicine in the posterior epidural space, hoping that it will go laterally and anteriorly and target the nerves which are irritated and would reduce the hypersensitization. Okay, this is local anesthetic with steroid. There can be failure because many times, because of adhesions or disturbed anatomy, the medicine may or may not reach the target. Same thing is true for caudal epidural. In this, the needle is put in the caudal epidural space and there is a chance that you are likely to enter the catheter in the anterior epidural space, which is the site of conflict. The disc is anterior to the spinal cord, all right, and it comes from the anterior side of the spinal cord and the nerves and presses. So there you can put the catheter right up to the L4-5 level and deposit steroid in the anterior epidural space. This is also likely to give good results. The mechanism is same as mentioned, and failure here again can be because of adhesions or disturbed anatomy. In transphenomenal epidural, what you do is basically you go oblique and enter the intervertebral foramen. Now, why this is most important is in intervertebral foramen lies the dorsal root ganglion. In our first slide, we have seen the dorsal root ganglion is a site of interest. This is a place where both the somatic and the sympathetic supply of the disc and the nerve root is basically at one place. So the moment you put steroid here and local anesthetic here, there is more likelihood of desensitization and thus pain relief. Depends upon which level you are giving, bilaterally or unilaterally. Again, here also, because of the disturbed anatomy or adhesions, one may or may not be able to reach the target and may or may not be able to give the results. But generally, the results are good. Now, this is something new, distal sodium channel block. The renowned orthopedic surgeon Dr. Gore, Dr. L. Prakash, and Dr. Divagar. These people have done excellent work and find out various peripheral spots which if you inject you get the same effect as epidural, and they have named it as distal sodium channel blocks. There's a book on it. There's a theory that basically the nerve which we see is basically working as a single unit. So either you block it up there in the spine or down there in the periphery. The result should be same. And they have got the results and I have followed them and I have got the results. Okay. But then again, a lot of study goes into it as to what is the exact level, which side, you don't miss any single level. Okay, and sometimes you need to repeat, but this is definitely some new thing which has come up and it has reduced, at least in my practice, lot of number of epidurals. All right, hypodermic dermatomal needling, this is what I discovered, say around 12 to 13 years back when I was reading the spinal cord stimulation. In spinal cord stimulation, we know that we are basically stimulating the dorsal horn, okay, dorsal column. And in dorsal column, in that actually we are stimulating the A beta fibers, leading to stimulation of descending inhibitory pathway, leading to release of endorphin and pain relief. The cost of spinal cord stimulation is very high. So at that time, we had some poor patients. I thought, why not think some other option which can have the same effect? Then I thought that what you get in TENS is basically get control theory. This is also gate control theory. Here it is more invasive and appropriate, going right up to the level and the site. Okay, then what can I do? So I thought, let me study A beta fibers. I studied A beta fibers. Then I realized that the peripheral end of A beta fibers is under the skin at the base of the hair follicle. So I thought, why not put a small needle under the dermis, that is hypodermis, and see what happens. And to my surprise, I got excellent relief in my patients. And so started my hypodermic dermatomal needling journey. I have published one paper also, and I have a case series ready, which I'll be publishing soon. Basically, it works on gate control theory of pain. And as I said, pain is carried by A delta and C fibers. A beta fibers stimulate the descending inhibitory pathway and release endorphin. Peripheral ends of A beta fibers are under the skin at the base of the hair follicles. Putting hypodermic needle there stimulates the A beta at its peripheral ends. This relieves pain, and this may need repetition. I usually do it every weekly once for 3 sessions, and in almost 95% of the patients I am getting lasting pain relief. As I mentioned, there are few other methods like intradiscal platelet-rich plasma and intradiscal autologous stem cell therapy. In intradiscal platelet-rich plasma, basically patient's blood is collected, then the plasma and platelets are separated, and the plasma and platelet are taken and injected into the disc. The whole idea is to reduce the degenerative process and promote healing because platelets have growth factors. Then further extension of the PRP is intradiscal autologous stem cell injection. Here the blood is collected, stem cells are separated, and then they are injected under live fluoroscopy right into the disc. The same idea. Basically, the internal disc disruption, or IDD, which we usually call, involves decrease in cell density, increase in inflammatory factors, and overall reduction in the synthesis of ECM. Use of cell-based therapy, especially implantation of autologous or allogeneic mesenchymal stem cells, may be potential therapeutic strategy for early disc degeneration. If I put you in nutshell my experience over years, out of my 20 years of pain management practice, initially I used to use decompressor, but then I once had patient who had a lot of pain after the procedure. Then somehow I was averse to it. Then I started giving bilateral dorsal root ganglion block. Why not block the nerve supply of the disc and let's see. And bingo, the results were excellent. I found DRG blocks much better and safer with less post-procedure issues and quicker and better results. Therefore, I continued it throughout. Of late, after reading the sodium channel block which I mentioned, I started using sodium channel block. But then I studied that further and I saw that it closely relates with many nerves. So then I studied the dermatomes and I realized that the particular dermatome has a root value in some nerve down there. So if I block that nerve, probably I will get the same effect as what you distal sodium channel blocks give. Basically, the points are nearly same and I'm using the same thing, but probably somewhere I have changed to my what do you say understanding, and I call it peripheral nerve block. But yes, basically it is a offshoot of distal sodium channel block, and I give full credit to Dr. Gore, Dr. L. Prakash, and Dr. Divakar for such a wonderful gift to this field, distal sodium channel block. I have extrapolated it to peripheral nerve block. Let's see if this works. It still gives better results. That's my perception. I may be wrong. So I'm giving peripheral nerve block at ankle and near wrist. Of course, most of the blocks are close to distal sodium channel blocks. Only one point differs. Okay. Coming to the next slide. For L4 and L5, what I do is the saphenous nerve block at ankle. For L5S1, I block superficial peroneal nerve block at ankle. For C5, the radial nerve block is given just above the lateral epicondyle. For C6, the first interdigital nerve block is given. For C7, the median nerve block just proximal to the carpal tunnel is given. For C8, ulnar nerve just above the medial epicondyle is given. The fundamental is in discogenic pain, segmental nerve and dorsal root ganglion are hypersensitized, so desensitizing them may relieve the pain. And this is done by blocking the peripheral nerves. An interesting thing is, I have started giving only local anesthetic, no adjuvant, no steroid, no clonidine. I just tried it and I've got good results lasting almost for more than 5 to 6 months, and most of the time this nearly solves the problem. There are 5% of the cases where I need to repeat, otherwise most of them have done well. But I tell you honestly, if there are sensory and motor disturbances, then you should not resort to these kind of things. You should do it when you don't have those four red flags, that is loss of sensation, loss of power, bladder and bowel issues. If they are there, you should not fiddle. You should straight away send it to spine surgeon. Or if you're doing endoscopic discectomy, go ahead and do it. So every few years, as I told previously, some procedure dominated and then fizzled out, replaced by the new procedure. Nowadays, disc effects and endoscopy is done by many people, while nerve desensitization by various methods is preferred by many. I prefer the chemical method more than anything else, but the choice may be yours. Your training and your mentor counts as to what to do best, right? But remember, patient is interested only in relief of pain without complication, at affordable cost, and without much repetition. Therefore, come to correct diagnosis. Choose best option to satisfy above needs. Get complete training to develop skills and knowledge to be able to give the best results and avoid complication. And remember, be clear legally by proper informed consent and taking due care. Thank you very much. I have tried to cover up as much as possible in the subject of managing the discogenic pain. Here, I have not gone into the technique of various options, as there will be separate videos for them. This is overall management of the discogenic pain, choosing as to what to do. Thank you very much. If you have liked this video, I would suggest please press the like button, share it with your friends and those interested in learning pain management. This is a free resource, and uh, subscribe my channel. Thank you very much. Thank you.